All right, welcome everybody. Hopefully you're able to put in some good work there. If you want to join and do the Twitch, then you can ask some more questions and list your chat tasks there. So this first question, hopefully you guys are doing great, by the way. Wonderful day. So in order to answer the questions about these chemotherapy drugs and where they affect, we have to know the cell cycle, right? And so I've drawn it out here on my notes. I got a little iPad here that'll keep improving this, but basically the G0 phase, that's your resting phase. So this is the non-dividing phase. And I'm gonna turn down the volume here. And then the G1 phase, this is when the cell is going to be growing, right? And then you have your S phase, that's the synthesis of the DNA. And then the G2 phase, that's when you prepare for the big event, which is of course mitosis, right? So here is where the DNA is checked, and that's gonna become important later. Now, regarding anti-cancer drugs by the cell cycle phase, so starting out with the S phase, we have certain drugs that will drop or block the DNA synthesis, right? Sorry, I keep saying the wrong thing. Okay. S phase, DNA synthesis, right? And so drugs that block the DNA replication will work here. So what are some examples of those? Can you think of any in the chat? Well, one of the bigger ones that you should immediately be thinking of, methotrexate. Methotrexate. That inhibits dihydrofolate reductase. Also, another one you should be thinking of, 5-FU. And what you need to know about that is mechanism of action. That inhibits, write this out for you, thiamidylate synthase. All right, so you have to know the mechanism of action of that one. Also, cytarabine, some other lower yield drugs, another big one they like to ask in the context of sickle cell is hydroxyurea. And that inhibits ribonucleotide reductase. And then one more here in this S phase is the topoisomerase inhibitors, right? Topoisomerase inhibitors, can you think of some of those? Well, one high yield one, etoposide. That's a topoisomerase inhibitor. And what that does is it prevents the DNA unwinding, okay? So all these have to relate with DNA synthesis, and that's how you should think of them because they are involving the S phase. Then we move over to the mitosis. This is the reason why we have this whole cycle here. So now we're on the mitosis phase, and hopefully you can see that there. All right. So these drugs stop the cell division, and how do they do that? They mess up the microtubules. And so these ones, you think of the vinca alkaloids. So an example of that is vincristine. Your vincristine and also vinblastine. So the VINs. The VINs. And the cool thing about this is if you flip these V's around both ways, then it turns out to be an M like that. And that's how you remember these VINs involve mitosis. So that's a little memory trick to help you know that the vinca alkaloids, they inhibit microtubule polymerization, and so you can't form the spindles. If you can't form the spindles, you can't undergo mitosis, right? Okay, so hopefully that makes sense. Also, the taxanes, like paclitaxel, taxol, right? The taxol. Okay, so those stabilize the microtubules, and so that means if you're packing the taxol, think of this like an axle. You're packing the axle, and so it can't break down. You're packing the axle, and so now it can't break down. So these microtubule affecting drugs are going to be involved with M for mitosis. So you should think of V together makes an M, and then also that's in mitosis and microtubules for mitosis. All right. How about the G2 phase? So this one is the DNA damage repair phase. Drugs that cause DNA damage act here, right? And so the drugs that cause DNA damage, bleomycin. Bleomycin causes DNA strand breaks, right? Like pulmonary fibrosis, and also etoposide. All right, that blocks the topoisomerase 2, and that also damages the DNA. And there are also some non-specific kind of drugs involved in this pathway, and these can attack any phase, including the resting phase. Even if you're at G0, they can attack there as well. And these are basic alkylating agents. For instance, cyclophosphamide, which inhibits the cross-linking of DNA. So cyclophosphamide is one of them. Anthracyclines, like doxorubicin, is one of them. Those intercalate DNA and generate reactive oxygenating species. So these ones I'll just put on the side here. Alkylating agents alkylating agents, like cyclophosphamide, super high yield drug there. And let me know if this is answering the question. And if you have any more questions about this, I want to make sure that I'm on target. And then I'll just concisely kind of mention all of this here. And I got to make sure that that this is still running here. Restart the capture and have to make sure my iPad is still running. 1 second. iPad. Where'd you go, iPad? There you are, iPad Shorts. And I have to go back to the Zoom because it just crashed. Oh no. Window capture Zoom. Hold on, I have to go touch that over here again. My computer runs out of memory because of how many things I'm running. Helps a lot. Okay, good. And wow, it doesn't want to find my Zoom. This should work. Wow. Man. The iPad on the screen is dying. Okay, there it is. I just had to like choose something and then I had to exit out of it again. That was wild. Okay, so here's my iPad again. Yeah, you can have multiple questions for sure. Absolutely. 100%. Super happy to help. And so these cell non-specific ones, I was just going to say, and I'll make a quick recording on this too, so I can post it to people on the channel. So we'll just start with this. Real quick, I'll just kind of recapitulate what I said here, but alkylating agents, and then also anthracyclines, right? Anthracyclines, like doxorubicin, and also the platinum drugs as well, platinum. Okay, so those are non-specific, cell cycle non-specific. All right, so really quickly, go ahead and ask that question. I'm going to make a recording on this so that everybody else can have answers to this question. Because if you're asking it, I think everybody else is going to have a question too. So 3, 2, 1. Okay. So this is in response to a question in the chat about anti-cancer drugs by cell cycle phase. So first, understanding the phases. You have this right here, your resting phase. And then you have your cell growth phase. And then you have your S phase with DNA synthesis. And then we have prep for mitosis in our G2. And then we actually have the mitosis. And now, how do you memorize these drugs? So you should group the drugs by their phases. And we'll start here with the S phase, that's DNA synthesis. And so the drugs you should think of are methotrexate, 5-FU, hydroxyurea, and etoposide. And you have to know the mechanism of action for each one. So methotrexate is inhibiting dihydrofolate reductase, and 5-FU inhibits thymidylate synthase, and cytarabine is less commonly tested, but that inhibits DNA polymerase. And then hydroxyurea, that inhibits ribonucleotide reductase. And then topoisomerase inhibitors like etoposide, those guys prevent DNA unwinding. All right, so there's DNA synthesis drugs, you have to know those. Next, G2. So in this G2 phase, you have the DNA damage repair. So drugs that cause DNA damage are going to act here. So bleomycin, for instance, that causes DNA strand breaks, and you also have a risk of pulmonary fibrosis. Etoposide as well here. This blocks topoisomerase 2, and that causes DNA damage as well. And now we go over here to mitosis. And that's the reason for the cell cycle, right? We got to divide. And so mitosis here, we have the V's. And if you mix these V's, you can form an M, which tells you they're both going to be affecting mitosis and microtubules. So MM. So the V's, the vinca alkaloids, stand for vincristine and vinblastine. They inhibit microtubule polymerization, so they can't form spindles. And also taxanes, like paclitaxel. You pack the axle, and so it can't be broken. So you can't break the microtubules. All right, and that's everything. Cool. Oh, then the non-specific drugs. The alkylating agents, the anthracyclines, and the platinum. These guys can act, they're non-cell specific, but like an anthracycline like doxorubicin. So hopefully that's helpful. And I got to clear some storage because it just crashed again. So just give me 1 second. Let me know if you have any questions on that stuff while I get this running again. There it is. Now it's running again. Got to free some space. Man, I got the itch, even though it's not even allergy season. Okay. So if there are no other questions, I'm going to start the ambient music and we'll keep locking in again. We can answer the questions the next break period too. All right, there was a question on prosthetic valves. Okay, we'll definitely cover that one in our next little break session. Sounds great. Oops, sorry you couldn't hear me. Hello. Hopefully you guys are able to get some work done there, and hopefully this break was good for you. So now I'm going to share my screen again. I just cleared some storage on my Mac, so hopefully that helps. Let's try this out. Oop, not quite here. 1 second. Oh no, it died again. Okay. Oh well. I'm gonna purchase a software that's gonna like get rid of some of this empty storage, the storage space on my computer. But what I was going to say is it's all about. I can't share my screen, unfortunately, until I download the software and delete some storage space. But basically, it's on the left and the right side of the heart, right? So your aortic is on the right second intercostal space, and the pulmonary is on the left intercostal space, the second. And so if they show you a heart, you have to understand that it's the patient. Usually, the way to think about this is you're looking up the skirt, is the way that they say it. And so that'll just help you remember it. And so left is right, right is left, right? And so the aortic valve is on the second right intercostal, and then the pulmonary is on the left second intercostal. And also, if it's about prosthesis, then the context is going to help you answer the question, because if it's an elderly person, then they're probably going to have aortic valve problems with like aortic stenosis or regurgitation. That's very common in the elderly, and that's over the spine area. If it's prosthesis for somebody with a pulmonary valve, then it's going to be more tetralogy of Fallot, and that's on the left upper chest area. So it's really about the left versus the right side of the heart. I would literally just draw a line right down the middle, and then if it's on the right side of the heart, then it's the aortic, and if it's on the left, then it's the pulmonary. And that's how I would answer those types of questions. So hopefully that's helpful. I got to do my Apple Pay real quick. I don't need antivirus software, right? Nah. They're trying to bundle me together. So hopefully that was helpful there. Yeah, nice. Any other questions we can answer? Downloading software to get rid of all this junk I have on my computer so I can screen share a little bit more. Okay, I see your question. Right. I think this is like one of those UWorld questions, if I remember right. Sorry, I'm just finding duplicates and deleting them. But IgE mediated is true anaphylaxis, right? So the mechanism there is type 1 hypersensitivity, so prior sensitization. What happens is the allergen cross-links on the IgE of the mast cells, and that causes degranulation. That's IgE mediated. That is true anaphylaxis. So for that one, you require prior exposure. And there's rapid onset after re-exposure, and it involves the mast cells, the basophils, the histamine, and also the leukotrienes and the prostaglandins. That whole thing is activated. So think of peanut allergies, think of that kind of stuff. Just one second here. I'm going to grant access. Finding duplicates. Allow. So yeah, allergy, prior exposure, type 1 hypersensitivity, all of that should make you think of IgE mediated. That's true anaphylaxis. Okay, only found 45 kilobytes. That's nothing. And then the non-IgE mediated, that's the direct mast cell degranulation. So non-IgE is whenever that you have agents that just trigger the mast cells directly, releasing without IgE, right? And so for those, you don't need any prior sensitization. It looks very similar to anaphylaxis. There's rash, hypotension, and bronchospasms. And the culprits are going to be radiocontrast dye, opioids, vancomycin, like red band syndrome, is a perfect example. In fact, that's probably what they'll give you is red band syndrome. And also muscle relaxants like succinylcholine and terbicurinine. And so, how do you distinguish between these? Because you're going to be asked about this for sure. If they maintain or if they mention that there's like prior exposure and there's like an allergen, then it's IgE mediated every single time. If it's the first time that they've been exposed, especially like a drug or contrast opioid, then it's non-IgE and it's a direct histamine release. Direct histamine. So they look the same, but the mechanisms are different. Does that help? Hey, Archie. Hey, hope you're doing well too. Good to see you, my friend. Good to see you. Archie's the man. Let me know if you have any questions. I'm clearing some space on my Mac right now. That's why I can't share my screen. I have like an error. That's the reason why. Clearing the space on my Mac. Looks like I'm going to buy this stuff. Whoa. So if that was prior exposure, then that would be IgE mediated. If it's the first exposure from a drug or contrast opioid, that's non-IgE direct histamine release. That's needs there. Quit without saving. And I'm going to undownload that software, and I'm going to download a new one. Yeah. The sneeze. I got something. There's some allergies in this room. Okay, guys, I just purchased the software so I can remove all this junk that I have on my computer. Let's delete all this stuff immediately. Cleaning duplicate files. We'll see if it was worth the $20. I think it will be worth it. I think so. I have to go into my settings and cancel the subscription because I don't want to pay that next year too. And in the meantime, let me know if you have any other questions. Okay, yeah. Archie says, can you explain methemoglobinemia? 100%. Yep. So methemoglobinemia, what you should think of is normally you have hemoglobin and it's in its ferrous state. So ferrous state is Fe2 positive, right? And then the ferrous iron, it binds the oxygen reversibly, and that allows the oxygen delivery to the tissues. That's how it works normally. But if you have methemoglobinemia, then you have iron in the hemoglobin that's oxidized into a ferric state, ferric, and that has Fe3 positive, right? And so then they have ferric hemoglobin, which is methemoglobin, and that cannot bind oxygen. It just can't. And so that causes, if you remember those charts, it'll shift the curve, the O2 hemoglobin curve to the left. And that means any oxygen that is bound is held super duper tightly and is not going to be released into the tissues. And so the result is you have functional anemia. You also get tissue hypoxia because the tissues, even though you have normal oxygen, it can't bind. That's the whole deal. It can't bind. You have to know the mechanisms as well for that. And the mechanisms are going to be nitrates and nitrates. Like I've seen a question on well water. Local anesthetics, for instance, lidocaine could be an exogenous cause. Dapsone, sulfonamides, those can all cause methemoglobinemia. Endogenously as well, you can have hemoglobin M disease. It's a mutant hemoglobin. And clinically, you have cyanosis, right? The lips, the nail beds, they're not improving with oxygen. And a huge giveaway for MBMEs is chocolate brown blood. They love telling you about the chocolate brown blood. So it can cause a lot of things: headache, dizziness, fatigue, shortness of breath. Those are the biggest symptoms that you'll see, but also seizures and arrhythmias. So the pulse oximetry is going to be 85% regardless of the O2 that's given. Give them all the O2, the saturation is going to be stuck at 85%. The PaO2, which is the arterial blood gas pressure, is going to be normal because the dissolved O2 is fine. The problem is the hemoglobin function. Okay, the treatment, what's the treatment? Methylene blue. That's an artificial electron carrier that reduces Fe3 to Fe2. Alrighty. Yeah, I think I got you. Methemoglobinemia. And so methylene blue is what you give them. And vitamin C also is an antioxidant, so it helps. Anything that helps reduce the ferric state to the ferrous state is going to be great. It's going to be great for you. But methemoglobinemia. Too much hemoglobin, right? Too much hemoglobin, too much iron, too much ferric state. You can't bind the oxygen, so hemoglobin is useless. Just completely useless. Oh my gosh, guys, check it out. 31 gigabytes was cleared from my computer. That's insane. That's awesome. That's a lot of clearance for my computer. I think it was worth the $20, don't you? Probably. Awesome. I bet now I can share my screen. Let's see. Let's see if I can. So I'm going to get my screen share on Zoom. And I'm going to go here. iPad Shorts, cursor, Zoom. Ha! Look, guys, it worked. It only cost $20. Awesome. Okay. Honestly, that was actually worth it. My computer's running a little bit faster now. Okay, did that help, guys? Was that helpful? I'm also going to activate the big right side of the screen here so you can see now we're in the beautiful different part of Hogwarts. And do you guys like this kind of stream where you guys lock in for a bit and then we kind of reconvene? I don't know. It's kind of fun. Hopefully that was helpful there. Cool beans. Cool beans. Any other questions before we kind of go into a little break? Or not a break, but rather have 22 minutes. We'll do a 22-minute little break here. Not a break, I mean like a lock-in session. All right, so we'll lock in, and I'll see you guys in 22 minutes. And then just feel free to ask me if you have any questions. Awesome, sounds good. Good to see you, Archie. Good to see you. Okay, let's turn on that ambient music. Now that I can restart this because I have space on my computer. Ambient music, restart the capture. Okay, there we go. And guys, enjoy. We'll see you in 20 minutes. In 20 minutes. Yes, I got you. Turn on the music. I just freed up some space so that way you can hear it. So there we go. Let me know if you want this volume up or down. I'm happy to get that going. I think that's probably a good volume there. Is just like in the greens. All right, guys. We'll see you in 20 minutes, and I'll ask what you've done, and we'll see you then. Okay, that was funny. Gunner level. That's funny. Yeah. No. We don't aspire to that, but that's hilarious. See you guys soon. Hey, you got the question. We'll cover this in 4 minutes. If you want to join the Twitch as well, then you can put the task you're working on, and then I can ask you how you've completed that task. It's a good way to lock in, you know? All right. Quick little break here. So we got a question about the right and left ventricle hypertrophy. And the way to think about this is hypertrophy causes there to be mass development. And I'll make a recording of this real quick. So regarding how to differentiate between right and left ventricle hypertrophy on an ECG. So with more mass, you're going to need more voltage. And a lot of these hypertrophies involve the pathology of increased afterload, and that causes increased ventricular wall stress. And there's myocyte hypertrophy. And so that's typically going to be via gene expression changes or protein synthesis. And so you have increased muscle mass that alters the electrical axis and the QRS voltage. So to answer this question succinctly, in the left ventricular hypertrophy, you're going to have the QRS elevations and the V5 and the V6 because that's on the left side of the heart. And then on the right side, you'll have also right shift. It's going to shift rightward, and maybe on V1, you'll see that increase there of activity. So the right axis deviation on the right ventricular hypertrophy, and then the left side is going to be left-sided. So you're going to have those V5 and V6 nodes. So hopefully that answers the question. Basically, left ventricular hypertrophy, you have QRS voltage in the V5 and V6 leads. You would also have a lower or decreased S wave in V1. And then in right ventricular hypertrophy, you have the dominant, I guess the lead would be in V1. You have the dominant R in V1, and also you'd have a right axis deviation on the axis, and also possible T-wave inversions on V1 to V3. So really it's just where they are on the heart and which leads they correspond to. Right, so ST depression, T-wave inversion on the lateral side, or the right precardial right ventricular hypertrophy leads. Cool. That's how I'd kind of break that down. Do you have any more questions about that? Maybe we could talk about what causes those diseases. Like the right ventricular hypertrophy would be, for instance, if you had chronic lung disease or congenital defects, then the right ventricle will bulk up, and depolarization shifts the heart rightward and also anterior. And so you'll see a dominant R wave in the V1, and that's right axis deviation, and also some inverted T waves in the right precordial leads. All right, so always tie this back to the clinical picture, I guess. So if they have hypertension, it's going to be left ventricular hypertrophy, and COPD, it's going to be hypertension of like pulmonary hypertension, so it's going to be right ventricular hypertrophy. So high voltages, axis shifts, the R patterns, the ventricular hypertrophy, all that stuff. Okay, hopefully that helps. And if you have another question, just let me know. Okay, so now we have another question about the associations with S2. All right, so let's talk about that, the S2 sounds. Okay, so I'm going to zoom on over here in my trusty little iPad. I think this is kind of a cute little thing, by the way. I like it. So I'm going to move this and make it a little bit bigger. I don't want to block your guys' nice view of the walking through Hogwarts. Imagine you're learning medicine in Hogwarts, probably learning different things. But yeah, so second heart sound is our S2. And that's produced by the closure of the semilunar valves. Okay, so let's talk about A2 and P2. So A2 is the aortic valve closure, and that's louder, and it's normally first. And then P2 is the pulmonary valve closure, right? Pulmonary valve going to the lungs. Aortic valve closure is going to be louder and normally first. And so you can split these sounds under certain physiologic and pathological conditions. And that's most evident in the pulmonic area. That's the left intercostal space. And so there are types of S2 splitting and auscultation sites, right? There's the physiological splitting. That's the A2 before the P2. That's the split that widens during inspiration. So you go increasing your venous return, what does that do? It's going to delay the P2 sound. Delays the P2 sound. So regarding the P2, second heart sound, closure of the semilunar valves. A2 is the aortic valve closure, louder normally first. P2 is then the pulmonary valve closure. They split. Physiological splitting is when you have A2 before P2, and the split widens with inspiration. So increased venous return delays the P2. And the associated condition for physiological splitting is just normal in children and young adults. Wide splitting. So there's a great separation between A2 and P2. It's wider with inspiration. So this is wider. That is because you're breathing in, the venous return is increasing. So there you could think of a couple of things. One would be pulmonary stenosis and right bundle branch block as well. That's a tongue twister. What if you have fixed splitting? Okay, fixed. Fixed splitting, well, that's if it's constant regardless of the bleeding. And if that's the case, you have an ASD. There's a left to right shunt. And that is going to be chronic, so you're increasing the flow, which would delay the P2. Right? You're delaying the P2. Right? Because as we discussed, A2 is normally first, and then P2 has that closure. So it's fixed with the ASD. Also, you can have what's called paradoxical splitting, and that's where we have P2 before A2. And that narrows or disappears with inspiration. And that's seen in aortic stenosis, right? Because that's going to lag behind, which makes sense. Or left bundle branch block. I said it right that time. Or hypertrophic cardiomyopathy, like you asked about. So if you have a single S2 sound, then you have severe aortic pulmonic stenosis and a single semilunar valve, like truncus arteriosus, right? Normally you should have the two because it's the semilunar valve closing. Hopefully that answered the question. And of course, if you're watching later, like and subscribe. That was crazy. It literally just cut off the stream. Nice. Good. Good. All right, time to go back to Hogwarts. We're walking through the halls. And if you guys want to, on our next little, we have a short break time of 24 seconds. If you guys want to head over to Twitch, I saw Archie did, you can go ahead and put the tasks that you're working on, and then I can comment on them when it's time. And when you're finished, you can actually click ! done, and it'll mark them off the list. So that's a good way to kind of stay accountable. If you want to do ! task, and then let me know what you're working on, and then we'll check in. So we'll see you guys in, what's the next timer for? 25 minutes. So let me launch that. So here we go. Timer 25. There we go. Oh, we got a question just before we go into the break. Is it okay if I play the music on the side? I don't even know if that distracts from what I'm saying or not, but hopefully it's relaxing. Also, what time is it over there for you guys? You know, is it like the middle of the day for you? Am I putting you to sleep when I shouldn't be? But yeah, let's go over these. You said, can you go quickly through the melanoma subtypes? Yes, I can. Let's make this bigger so we can see this, and I will also record so you can benefit for future students. All right, melanoma subtypes. Okay, so the most common is going to be superficial spreading, and that starts radially, and then it has ventricle growth. And so what you should think of there is going to be the trunk in men, the legs in the women, and it has the pagetoid spread. Okay, so there's the superficial spreading, and that is most common, starts radially and then vertical growth. The next type is going to be nodular. So nodular, this is the second most common, and here you have early vertical growth and then rapid invasion, and these guys are going to be aggressive, right? And they have a very poor prognosis. That's nodular. And then lentigo maligna, that arises on sun-damaged skin. Sun-damaged. 215 in Pakistan, nice. Okay, hopefully I'm not putting you to sleep. Sun-damaged skin, slow growing, radial phase predominates. All right, this is going to be on the elderly, and it's the lentiginous proliferation pattern. Then you also have the acral. We'll talk about that one, acral. And there, that's going to be on your palms, your soles, and also sublingual, right? It's more common in Black and Asian patients as well. Black and Asian patients. And you have Hutchinson signs of the nail, and it's not going to be sun-related. Not sun-related. Lentigo, sun-damaged, nodular, very aggressive, superficial, most common. These are the 4 most important types of melanomas. So superficial spreading, it has a slow start. It's most common, right? Nodular is super nasty and fast. Lentigo is going to be like a liver spot. So that's going to be sun-damaged skin. Lentigo, sun-damaged skin. Acral is Asian and African and atypical. Acral, Asian, African, atypical. There you go. Those are the melanoma subtypes. And what you can know too, like what they mention in Pathoma, which it's really good to go through these first 3 chapters at least of Pathoma, and I have a video on them too, is that these guys are going to show S100 positivity. And this is just a neural crest marker. And also you have to look for BRAF mutations. BRAF mutations. And the treatment is, I don't think you need to know that for step 1 actually. But what you should remember is the ABCDEs, the asymmetry, border, color, diameter, and evolution. All right. Okay. Hopefully that was helpful. Did I answer your question? And also, of course, if you're watching later, then like and subscribe. All right, let's enter our break mode. And I would love it if you guys would just go to the Twitch and then put in whatever task you have. Soon I'll get the YouTube working too, but that's what I'm working on in my break time. So we'll talk to you guys soon. Let me know if you have any future questions. Of course, I'm super happy to help. This is really fun. I love doing this.
Come on.
you doing? Good to see you again. Are you locked in? Alrighty, folks. Hopefully you guys were nice and locked in there. Got some good work done. Albinism. I hear you. Okay, so let's go over some melanoma. Well, last time we went over all the subtypes, so just testing you. Acral. What do you remember for that one? Black Asian patients, right? What about lentigo? Sun damaged skin. How about nodular? Nodular, early vertical growth, and then superficial is most common. All right, so we went over all that stuff, and now talking about Waardenburg syndrome. I forgot my second A. All right, Waardenburg syndrome and other pigment-related kind of disorders here. So first, these all involve melanocytes. Yeah, palm and soul, good stuff, good stuff. So melanocytes, neural crest cell driven or derived cells that are located in the basal layer of the epidermis. Yeah, bad one. Good. There's a little bit of a latency, but I see what you're saying. Yep, the basal layer. And so this produces melanin in melanosomes using tyrosine. Okay. So how tyrosine hooks into this is tyrosine via tyrosinase turns into dopa and then into melanin. Okay. So tyrosinase, what that does is you get tyrosine over here, and then you get that converted into dopa. And then from dopa, you get converted into melanin. Hence the melanin disorder of tyrosinase deficiency. So melanin is then transferred into keratinocytes, and it's not just retained in the melanocytes. Okay? Not just in the melanocytes, it goes over to the keratinocytes. Okay, so the melanin disorders you have to know. The melanin disorders you have to know are 1, albinism. And the mechanism there is you have decreased melanin production due to tyrosinase deficiency. This is type 1. Or impaired melanosome transport, and that's type 2. Impaired melanosome transport. That is the mechanism for albinism. Now, this is not due, and what they like to test you on This is not due to a decrease of melanocyte number. The melanocytes are still present, they're just non-functional. So the presentation is obviously, white hair, pale skin, the pink, right, is the photophobia and nystagmus, and also there's skin cancer risk, and the genetic is autosomal recessive. I lived in Guatemala, and there were plenty of people who had albinism because of the autosomal recessive disease, because of inbreeding depression over time. A lot of inbreeding occurred in that area. So you have an increased risk of squamous cell carcinoma, basal cell carcinoma, and melanomas. Now, Waardenburg syndrome with the 2 A's right here, Waardenburg syndrome. We'll talk about that one. So what do we need to know about Waardenburg syndrome? This is the failure of neural crest cell migration, okay? Fail of migration. And so you have defective melanocyte development, and the genetic is autosomal dominant. And they like asking about the PAX3 mutation sometimes. Autosomal dominant. And so here you have the white forelock, heterochromia, iriditis, and sensory neural deafness. And I think that's what you're saying in your comment, the deafness there for Waardenburg syndrome. So failure of migration, deafness, white forelock, and dystopia. This lateral displacement of the dystopia canthorum. So you have a child who has hearing loss, they have pigment changes, and they have distinct facial features. All of that is Waardenburg syndrome. Okay, so we've covered so far albinism, tyrosinase deficiency, Waardenburg syndrome, which is the deafness and the pigmentation changes in the child. There's another one. This one's the easier one to remember. Vitiligo. And that's where you have autoimmune destruction of melanocytes. So the presentation is irregular depigmented macules, and this is associated with other autoimmune diseases, right? So here you actually do have a decreased melanocyte count. So I talked about how the melanocyte here is the same count, but it's just dysfunctional for tyrosinase deficiency. But in vitiligo, you actually have a decreased melanocyte count. And this is common in perioral, the hands, the elbows, and also the genital areas. Okay, you can also have piobaldism, that's a congenital abscess of melanocytes in certain localized areas. So congenital. So you're born with absence of melanocytes. And so these two, vitiligo, and the congenital problems is having decreased melanocyte number. And this is autosomal dominant, and it's going to have stable depigmented patches since birth, often with the white forelock as well. And what was the other white forelock that we mentioned? Hearing loss, the pigment changes, right? All of that has to go with Waardenburg syndrome. Okay. Also, they could ask you melasma. That's a hormone-induced increased melanin production. Hormones are pumping out, a lot of melanin is happening. This is pregnancy, OCP, sun exposure, and symmetric hyperpigmented facial macules. So this is the mask of pregnancy, is what people like to call this. Another one is cafe au lait macules, right? Cafe au lait spots. This is increased melanin in the basal layer. And that's seen in neurofibromatosis type 1, a McCune-Albright syndrome. You have the light brown, the coast of California. And I covered that on a stage here, the different mechanisms of those. Tumor suppressor loss gene, and that's the neurofibromatosis autosomal dominant disorder, and McCune-Albright. They both have kind of some different mechanisms where McCune-Albright's like a constitutive activation of, I think it's the GS to the camp, causing just like the production of these macules and melanin production. Next, we can have post-inflammatory hypo or hyperpigmentation, and that's just inflammatory changes that change the melanin synthesis. So think acne, eczema, burns, and it's common in darker skin tones. Cool. That's everything. If you found that helpful, then consider liking and subscribing. There's another question in the chat. I saw Archie was saying, can you explain the cardiac tracings and aortic regurg? Yes, we can. So in aortic regurg, the aortic valve fails to close properly during diastole. Okay, so next question in chat is about aortic regurg. diastolic, right? So the aortic valve is failing to close properly and diastole, and that allows the blood to leak back from the aorta, into the left ventricle. And that causes left ventricular volume overload. Diastolic aortic pressure is going to be decreased, and you have a widened pulse pressure. Now, the changes on the tracings and the pulse pressure waveforms, what you have to know is during systole, you have a sharp increase during left ventricular ejection. And that's normal, right? We have a sharp increase in whenever the left ventricle is ejecting. In systole, you see a sharp increase. In aortic regurgitation, it has a normal systolic peak. In diastole, we have a gradual decline normally. But then in aortic regurg, we have a rapid fall in pressure. Rapid fall in pressure during diastole. So there's a super, super big plummet, and that's because of the regurgitation back into the left ventricle. So there's a steep drop in the aortic diastolic pressure due to the blood leaking back into the left ventricle. So hopefully that makes sense and answers your question there. And I think that's everything. Let me know if you have any more questions about that particular mechanism and the EEG tracings. All right, time for some Harry Potter. Also, feel free to write down your tasks and I'll be able to check in on them. Have you already done that? Let me see. Not yet, looks like. If you do exclamation mark, task, and then type it in, then it'll populate here. For instance, task, answer questions. Then it'll populate and it'll say, hey, task added. So you guys can go ahead and try that functionality if you'd like. All right, folks, time to turn the music on. Enjoy Hogwarts for a bit. Good morning, Renata. Good morning. Hope you're doing great. Time to lock in and get some good questions done. Good to see you. Yeah, kind of crazy. My sleep schedule has taken a turn for the worse, but at least I'm in line with Pakistan's time, which I think it's like 3 p.m. But still trying to get this YouTube function to work. It's proving more difficult than I thought. All right, 22 seconds. If you guys have any questions. If not, we'll cover just 3 quick ones for your next little break. All right, so here we are in the Slytherin common room, which is just great. So 3 questions, candida and duration. What does this involve? The T lymphocytes. That's the first question and answer. Next one, somebody has cystic fibrosis. What should you be looking for? Sweat chloride test, because the CFTR mutation makes it so you can't transfer that salt inside. And so you should look at the chloride levels in the sweat, and they're going to be elevated. Also, they could have the absence of a vas deferens as well, because CFTR mutations are responsible for the abnormal development of Wolffian structures. And so you have vasolagenesis and defective sperm transport. And then the other question here is an oxidative stress, which happens because of NADPH malfunction, the absence, right? Reduced glutathione, which is required for the reduction of peroxisome or hydrogen peroxide to water. And so this is going to stay in its oxidized state. It's going to wreak havoc, and it's going to be kind of similar to G6PD deficiency. And the cells you're going to see are going to have little bites out of them, bite cells. Okay, those are 3 little practice questions for you. The little Pomodoro timer says that you have a couple of minutes left, so hopefully you can take a little break. Let me know if you have any questions, and I'm happy to help. Looks like we're going through, is this Professor Trelawney's lab? Love it. Also, if you guys use exclamation timer in the chat, like Renata did, then it'll actually enable a timer, so you guys can have your own Pomodoro timers as well. Hey there, Archie. Good to see ya. All right, nicely done. That's another 25-minute timer. So if there aren't any questions, I was just going to do one little diagram here that's high yield for step 1. So this is a presynaptic neuron, and we have to know the tyrosine to dopa to dopamine pathway, and then it's going to be spit out into this clef where it can be received by the adrenoreceptor, and the drugs that act on these different parts of the presynaptic neuron are high yield. So cocaine, taking cocaine, that would inhibit the reuptake of the monoamines, norepinephrine, dopamine, serotonin, causing sympathetic stimulation. So hypertension, tachycardia is what you'd have there with cocaine. Tacopone, the apones, would stop the degradation of the COMT. So I'm just going to make a quick recording. This is the presynaptic neuron. And cocaine inhibits the reuptake of monoamines. COMT causes the breakdown into the inactive metabolites. So the apones, like entacapone, causes the lack of that degradation to the inactive metabolites. Metyrosine stops this step of tyrosine to dopa. And reserpine stops the dopamine to norepinephrine pathway. All right. It's a little high yield diagram. Everything you need to know about the presynaptic neuron. And that's all I got. Let me know if you guys have any thoughts, questions, and enjoy your 3-minute break if you're taking one. And if you're not, you can also just use those timers. And I'd love to see whatever you guys are working on. So have fun. All right, we got a question. So let's explain the heart block and also, yeah, for sure. What does it say? Botulinum as well, and the mechanism of action of botulinum toxin. For sure. We'll also talk about what's high yield there. And I'll make a quick diagram for you too. Okay, so with heart block, we think of the impaired conduction through the AV node or the His Purkinjes. All right. And so you have delayed or absent transmission of the impulse from the atria to the ventricles. Okay, so here's our nice little heart. Kind of hard to see here. Looks like a little apple. All right. And so in a heart block, you have impaired conduction through the AV node and the His Purkinje, and so you have delayed transmission from the atria to the ventricles. Okay, so this is electrical delay. And there are 4 types of heart block. There's a first degree, and that's the first degree AV block. And there are some EEG signs that you have to be aware of, like the PR interval is greater than 200 milliseconds, and basically has like one large box. But every P wave is followed by a QRS. So that's the first one. So every P makes a QRS, it just takes longer. Then you have to know the second degree. There's the second degree AV heart block. There are 2 subtypes. There's Mobitz type 1, and that is the progressive lengthening of PR until you finally drop one. So lengthens, 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 drop. All right, that's Mobitz type 1, second degree AV block. It's usually in the AV node, okay? Halloween colors. And so this is going to be a regularly irregular. So it's longer, 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 drop. I like to think of this as Mo Beats as like a DJ. And his number one go-to trick as a DJ is that he goes longer, longer, and then finally the beat drops, right? The beat drops. You said apple. National Apple Day? Crescent Seal, how you doing? I had no idea today was National Apple Day. That's awesome. All right, so right now we're talking about EV heart block, Crescent Seal. There's also Mobitz type 2. So we just talked about type 1, so here's Mobitz type 2. Mobitz type 2 is when you randomly drop the QRS without a PR prolongation. All right, so now he's an expert DJ, right? He's doing whatever he wants, and he randomly drops the QRS without the prolongation. Mobitz is the DJ, right? Mobitz type 1, he has one trick. Gets longer, drops. Mobitz, the DJ, type 2 is more advanced. He drops it whenever he wants. Okay? And Mobitz type 2 requires a pacemaker. All right, there's also third degree heart block. Third degree. In third degree, there's no relationship between the P and the QRS complexes. Complete disassociation, and this is seen in Lyme disease. Lyme disease. All right, and then that's it. That's heart block. Does that answer your questions? Hopefully it does. If you'd like, we can cover the EEGs, and maybe if you'd like to, I can make a quick video for everybody else. So I'll do that now. 3, 2, 1. Hello, everybody. We're covering the Mobitz type 1 and also type 2 and the 4 types of heart block. So, first degree, AV block, you have the PR interval greater than 200. That's first. Second, there's 2 of them, right? Mobitz 1 and also Mobitz 2. Mobitz 1, you have progressive lengthening. Mobitz the DJ, progressive lengthening, and then boom, you drop the QRS complex. Mobitz 2, you need a pacemaker, randomly drops it. He's more advanced of a DJ. Mobitz 2, he randomly drops it whenever he wants to drop it. All right? And then 3, this is the third degree heart block. There's no relationship between the P and the QRS complexes. Complete disassociation. Lyme disease is how you think of this one. And the 3, oh boy, we need a pacemaker immediately. Okay? So those are the heart blocks. Hopefully that helps. Let me know in the chat if you have any more questions about that. All right. We had another question. Botulinum toxin. Yeah, right. Yeah, of course. Happy to help. Super happy to help. I love doing this. Okay. So let's talk about botulinum toxin. And yeah, like inferior myocardial infarctions are more with Mobitz type 1, and then anterior is more with Mobitz type 2, but that's more esoteric. All right. So what is Clostridium botulinum? Here, I'll utilize my little iPad notes, and I should probably make this a little bit bigger so we can see. Okay. So Clostridium botulinum is a gram-positive, spore-forming anaerobic rod. Okay. And this is found in the soil. Also in contaminated food, especially improperly canned goods or honey. Those 2 things, very high yield. Canned goods, honey. Canned goods, honey. Botulinum toxin. And this inhibits acetylcholine release at the neuromuscular junction. So it targets, what you need to remember, is the snare protein. Targets the snare protein. It prevents exocytosis of acetylcholine. And so that site of action is the peripheral cholinergic synapses, especially at the neuromuscular junction. So no acetylcholine, no muscle contraction. If you don't have muscle contraction, what is that called? Flaccid paralysis, right? Flaccid paralysis. Okay, so foodborne botulinum, canned food stuff, right? Infant botulinum or botulism toxin, that's ingested spores through honey, right? You produce the toxin and it's floppy baby syndrome. And there's wound botulism, and that's when the toxin occurs locally at the wound, and this is seen in IV drug users. Okay, hopefully that helps. It's the snare protein. You're blocking acetylcholine release at the neuromuscular junction, and yeah, it doesn't grow in oxygen. It's anaerobic. If you found that helpful, like and subscribe. There you go. Did that answer your guys' questions? Do you have any more questions? Crescent Zeal says, I knew somebody with Lyme disease. I just talked about them with another person. Well, yeah, there you go. Okay. Bad person. I hope they repented. That's all I'm going to say. Fair enough. Wow. And Cytocon. Thanks. Yeah, of course. Super happy to help. Hopefully that was helpful. If you have any questions, let me know. Or if there's a way that you'd like me to change my explanation, happy to do that as well. Cool. Let's get some music up in here, shall we? Oh, we got another chat. I'll turn on the music real quick so we can hear. Association between a heart block and congenital lupus. Yeah. Okay. So we'll talk about that. And then the Mandelbrot set. We're doing some medical stuff right now, but we can definitely talk some mathematics for sure. I actually have a really cool video that I should show you on the Williams. I think it's called Williams set. But yeah, okay. So let's talk about heart block and congenital lupus. So yes, 3rd degree heart block in a neonate is strongly associated with neonatal lupus. Okay, so I'll zoom on over here and we'll talk about that. Let me just expand my iPad, if you will allow me here. There it is. I think it's a cute little iPad there. I gotta change that. So here we go. I'm gonna record this one too. There is association between a 3rd degree heart block and neonatal lupus. All right, that occurs due to maternal autoantibodies that cross the placenta. And so there are some culprits that you need to know. Anti-Rho. And anti-La. And so these maternal IgG autoantibodies, they cross the placenta and they damage the fetal cardiac conduction system, especially in the AV node. So these maternal anti-Rho SSA antibodies, they bind the fetal cardiac tissue and it causes inflammation and fibrosis of the AV node. Inflammation and fibrosis of the AV node. And that causes the irreversible complete heart block. And so the way they like to test this on step 1 is they'll say there's a newborn. They have a low heart rate. Let's say they have a heart rate like 50 beats per minute. And they have a regular rhythm. And the mother has a history of a rash and joint pain. And then the ECG shows complex of AV dissociation. So that bradycardia, 3rd degree heart block, and the mom is asymptomatic or maybe she has lupus, well, there's maternal anti-SSA or Rho autoantibodies. All right. So yes, there definitely is an association there. You have to monitor the fetal heart rate during pregnancy of somebody who has lupus. And also you have some prenatal use of steroids like dexamethasone can help with reduced inflammation, although that is a little bit controversial. Okay, hopefully that answered your question. Of course, if it did, like and subscribe. Cool beans. Mathematics. Sure, my mom was in schooling to be a nurse. She was a healthcare nurse for a little while, elderly in life, a caretaker. Nice. So the Mandelbrot set, yeah. I don't know much about it. What do you want to tell me about the Mandelbrot set? I love talking mathematics. I'm just not super adept in my math. So I'd love to hear whatever you have to say about it. Is that like one of those fractal things where it's like infinitely complex or something like that? I did watch a YouTube video the other day. I think it was on Williams formula where you can express complex code in mathematics. But I'm very interested in like fractals. Oh yeah, so it is about fractals. Cool. Yeah, just like infinite levels and fractals and honestly, like I wonder if there's something like deeper going on. I don't know. Blows my mind. Yeah, that's crazy. I'm gonna have to watch the videos on the Mandelbrot set for sure. That stuff blows my mind. All right, guys, any other questions before we dive into the 16-minute work session? Speak now and forever hold your peace. Also, let me know if there's anything you'd like to see changed here in the community tasks or otherwise. Hey, Daweed. Oh, hey. How's it going? So one thing you can do is you can say done 1. If you guys finish a task, you can click done 1 and it pings a server that I built yesterday with Daweed and it'll cross off a task on your list, which is pretty cool. You can also do remove if you want to remove a task. It looks like Renata has 2 minutes on her timer. You got this. Oh, Dawid, are you talking about Daniel Nierditsky? I was watching the VOD of his Twitch stream the other day, and that is so depressing. Yeah, the chess world was shocked. Well, our favorite, I don't know, I don't want to speak for you, but my favorite personality on YouTube died. And it wasn't good. And I saw him on stream like two days before. Oh, for sociology. Huh. Okay, gotcha. Well, I guess from a mental health perspective, you could say, depression, anxiety, alcohol, drugs, gambling, chronic stress, all that stuff. Maybe drugs of abuse, right? Sociology, like what else can cause it? I'm not entirely sure. Hope that's not on step 1. The sensitivity and specificity is enough for med students. Yeah, that's totally fair. Sensitivity and specificity. That's funny. And I love this stream because, here we have people from all walks of all different professions, and there are a lot of medical students in this stream. There are physicians, and there are also people who like chess. This is generally who's here. But I don't want to be too much of a buzzy noise in your guys' ear while you're doing work. But I love this. This is fun. In my book, it says legal changes, introduction of divorce laws. Okay, there you go. And Crescent Zeal loves chess. Well, we should play sometime. Add me at this, SteamTams81. And we'll be friends. We'll be friends. It'll be good. Yeah, chess.com is good. Lichess. On Lichess, it's this. Put it in the chat. You can add me on either. I'm like 1900 on chess.com and about 2200 on Lichess. Gotcha. Nice. Crescent, did you come from YouTube? 1900. Yeah. I try to get to 2000. I've been to 2000 before. Nice, man. That's awesome. You're making your way up. Crescent, did you come from YouTube? And also, Renata, congratulations on your timer. It's complete. What task was Renata doing? Content review. How was the Renata? No, you invited me to the collab that one day. That's right. That's right. We did the collab thing. Okay, cool. I've figured out how that works, by the way. I did one collab the other day. Really cool stuff. I'm down to do another collab at some point. Even though we couldn't get it figured out. Okay. Well, looks like we have 13 more minutes of grinding. So I'll probably get back and do some more high yield content. What I'll do is I'm building a course, and so I'm going to go through that course and I'm going to list high yield content for our next break. So you guys can do 12 more minutes of work, and then we'll check in then and go over a question or two. So speak now, forever hold your peace. Here we go. Welcome back to Hogwarts. Hello, good morning. Mahlers, how you doing? Are you working on a task? If you are, you can click !task. Oh, you're on YouTube. Hey. Welcome. A lot of us are on Twitch right now. We've kind of all transferred over. If you want to join, there's some cool features that I built into the stream. But good to see you. Good morning, Ma. Good morning. There you go. Streaming right now, Crescent. Nice. Good to see ya. You've burped 7,000 times? Bro, that's wild. That's like 6 burps a day. That's a funny comment. What Saida said, that's really funny. I guess medically, you know, if you're burping more than 10 times a day, then you could watch out for, you know, heartburn or reflux problems. GERD, right? Maybe you do have GERD. Probably get like a hiatal hernia. Oh, we'll see if that works or not. Okay, well, maybe that makes sense. Heartburn that turns into gallstone issues. Maybe you have a hiatal hernia or something like that. I don't know, maybe you're talking a lot and you're breathing a lot. Acrophagia, something like that. Acrophagia is when you swallow a bunch of air to stimulate the belching. No, you're Gucci. Gucci with the gallstones, baby. Yeah, maybe it's a side effect of talking so much and swallowing air. Burp. I think it's cool that you took track of it, though. Way to go. And Renata, congrats on finishing your task. Really good job. Oh, you're a vocalist. You be swallowing that air. Wow. Also, Renata, I think if you type in exclamation timer 30, it'll make at least a timer for you. And then maybe you can do a space break. All right, Daweed, are you locked in? We only have 4 minutes left. And then I'm going to talk about a medical fact. Locked and loaded, baby. Let's go. Here, I'm gonna remove my task so you guys can see more. Who, Joe Mama? I don't think so. All right, 3 minutes of lock-in left. I can tell you're a streamer. You got that. You got that Riz. Hey, Kiani is my dad. Welcome to the stream. You fell for Candace. Yes, I'm prone to fall for things, that's for sure. Kiana's my dad. Welcome to the stream, Kiana's my dad. You do got that, Riz. You're a quantum Rizzler. A quantum Rizix professor. Kiana's my dad. Welcome. This is your first time on the stream. I hope you're doing great. We're all just walking through Hogwarts here together. We're just studying medical content. Yeah, Crescent Zeal, you got a good personality on you. You really do. Crescent Zeal, do you play Toontown? And Connie, is your dad's name Connie? Is that a true statement? Thank you. So on this stream, we do work for 25 minutes, sometimes 50, and then we take a break for 5 minutes, and we talk about medical content. So each break, I have medical content. Am I God? I'm not God. Not even close. I don't even know how to respond to that. Connie says it's a long story. Did your dad go out to get milk? My dad did. He came back though with cereal. We had a great time. Not the God, but a God. This is not written that your children will be like gods. Because you're God in your mind? Wow. Is that why you burp all the time? Okay. I'm going to lock in for 30 seconds, and then I'll lock out again. Okay. Hey everybody. How was your guys' work session? Did you guys get a lot done? Let's check the tasks. Oh, Renata, I think you have to click exclamation mark, done, space 1. Like this. So if you want to complete a task, you do done 1 like that. And if you want to make a task, you do task, make a task. And if you want to remove, you do remove 1 like that. So for instance, I go here and remove 1. All right, so here we go. Time to go over some medical content. So today, in this break, here's what we're talking about. What happens when you have a sperm, when you have 2 sperm that hit the ovum? What then, huh? Well, there's actually high yield. So let's discuss it. Okay, talking about hytidiform moles. So a hytidiform mole is a form of gestational trophoblastic disease that can be either complete, like these guys up here, or it can be partial. Complete, partial. And the patient has a complete if they have 46XX or XY. And you have to know the mechanisms, right? So in white, this first one, here you have kind of an inactivated ovum. That is to say the ovum has inactive maternal chromosomes. And so the father's sperm comes here and now it duplicates. The paternal chromosomes duplicate. And then you end up with 46XX. That right there is a complete mole. Next, you have the ovum with inactive maternal chromosomes. And you get fertilization by 2 sperm. 2 sperm. Come on in there. That causes a complete mole, and it can either be XX or XY. The last one, and this is a partial mole. This is where you have a normal ovum. So you have that 23 in the ovum, 23X, and let's say 23X or 23Y. That obviously makes 69. And it could be either of these combinations, but the thing is it has to have an X. Everything else is variable. All right? So that's the hytidiform mole, and that's how it's presented and tested. Basically, a complete hytidiform mole happens when you have an empty ovum that's fertilized by haploid sperm, and then maybe you have a duplication of the paternal genetic component, and that gives you this XX genotype. Cool. If you found it helpful, then like and subscribe. Do you guys have any questions in this break? Any things you'd like to go over? We have just 2 more minutes with each other here. Oh, Crescent Zeal says, I'm a Reiki healer also. Blake, love it. I don't know what a Reiki healer is. Should I know what that is? Yeah, I'm not entirely sure. You're going streaking? You're on a 3-stream streak? Dude, legend. For those of you who don't know, Profiteer Gaming is my twin from another universe. We both got started doing ACT, SAT tutoring, and we both stream, and we both play chess. He's just more handsome than me. Yes. Yeah, that's a good one. We'll talk about cleft lip and cleft palate in this next 1 minute that we have together. For sure. Oh, thanks, Crescent. Appreciate it. All right. So cleft lip and cleft palate, these are congenital defects that are caused by failure of the fusion of facial development in the embryo. And so they occur together, but they're actually separate embryological defects, and they occur at different times and have different structures. So let me make a recording for future students who watch this. Okay, so let's talk about this. The question is about cleft lip and cleft palate. So the cleft lip is usually at weeks 5 to 6. The cleft palate is at weeks 7 to 10. All right? And you have to know what it's a failure of. So cleft lip up here, this is a failure of the fusion of the maxillary process with the medial nasal process. So this is important because this was tested, I think, on MBME 26, I want to say. Fusion of the maxillary process with the medial. Okay? The medial nasal process. So normally the medial nasal prominence, it fuses with the maxillary prominence to form the upper lip. That's how our upper lip forms. It's the fusion of maxillary and medial. And if you fail, you have a cleft lip that's unilateral, or it could be bilateral. And then the embryologic origin here, this is the first pharyngeal arch derivative. First. And you should remember that because it's the first thing that you think of. All right? The presentation is you have a visible gap in the upper lip, and it can extend all the way up to the nostril. I've seen that before. Now, cleft palate, weeks 7 to 10. This is the fusion of the lateral palatine shelves with the nasal septum and median palatine shelf. So here the palate, it forms from the lateral palatine shelf, fusing at the midline. And if it doesn't fuse, then you have a cleft at the roof of the mouth. And so this can involve the soft palate or the uvula as well. So you have an opening in a hard or a soft palate, and there's a feeding difficulty with this one. And there's also a risk of otitis media. Otitis media. There's a risk. Okay. So that's the most important high yield stuff. Basically, on test day, if they say failure of maxillary and medial nasal fold, you know it's cleft lip. If they say failure of the lateral palatine shelf, it's a cleft palate. And if it's a newborn with nasal regurgitation, then it's a cleft palate. All right, and then trisomy 13 is seen in both. If you found that helpful, then like and subscribe. All right, Profiteer Gaming. Nice. Profiteer Gaming. Other than that, yes, we are twins. Honestly, like, super glad we got to meet. Like, my life is definitely better having met you. So that's the cleft lip and cleft palate. And how do you pronounce your name? Is it Saida? Saida. It's a beautiful name if it is. Either way. Okay. That concludes our little break session here. So now the 22-minute timer has started. Say deal. Ah, Seydal. Did I say that right? Seydal? Seydal. Nice. Seydal. Nice. Okay. Well, guys, we have 22 minutes of lock-in, so let me know of your questions, and then whenever they come back, I will be ready with another practice question if you guys don't have any. Otherwise, we'll just hit all the questions you have. We'll see you guys in 20 minutes. And yes, we'll do bladder and urethral injury next, yeah. And then Reiki healer with music and my voice and touch, very easily. Just being a decent human being. I'll take one Reiki heal. Thank you very much. Love that.
Hey, can you hear me? I think you can. But I can't hear you. Why can't I hear you? Yes. Really? Is that what it is? Is that a year and a half ago? That's awesome, brother. Thank you for the I gotta mute your stream now. Wait, time out. I gotta mute your stream now because wait, I'm hearing myself twice. There we go. Hey, at least we got this working. I'm rewritten. I did try playing Clash at one point. I did not. You can't hear him relentless on stream. Hold on. Oh, you know why? Because I gotta put that window. Or no, you know what I gotta do? I know what I gotta do. I gotta do desktop audio. I gotta switch. There we go. Relentless. Right. Oh, you remember this? Wow, that's crazy. Good, good, good. That's awesome. Uh huh. Now you remember. Wow, that's funny. Just because of the burping. So, guys, in my chat, this is Blake on call. We tried doing a collab the other day, and well, here we are. This is working. So, this is an awesome Blake. If you want to, I guess, give yourself a little background for yourself.
Yeah, sounds good. And also, my chat was saying, "Hey, we can hear your friend." Sorry, I was doing a study stream and I didn't want to distract them. But
Sorry.
I wanted to stop by and say hi because I saw you a year and a half ago. And I was like, I recognize Crescent Zeal through the burps. So
well, Microzeal back then, but I did a name brand.
It was Microzeal. That's it. It was Microzeal.
Microzeal. Yes, that's why the zeal is recognizable. I live by that word like for the longest time. So yeah. So.
Okay, I just want I'll have my stream really quickly. Just like say hi real quick. I don't know if there's a way to show you or whatever your stream.
I'm not sure why. Yeah, I'm not sure why. I thought our chats would link up, but they're not linking up. It looks like, but I thought that's what would happen.
Ah, there we go.
Shared chat started. Oh, because you probably had to hit something on your end, maybe. There we go.
Yeah.
Working now.
Okay. But yeah, my chat, we're all studying together, so it's like I don't know how distracting this is to everybody, but I had to say hi. So hopefully it's cool with everybody.
So regarding my chat, because I have a bot that's going on, and that's why like automatically it's gonna have songs that are playing on my Spotify. So that's gonna keep popping up on your chat. Hello, Prophet. How are you doing, brother? Prophet's here.
Yeah, so Microzeal, but now he's Crescent Zeal. I saw him a year and a half ago, and I subscribed. So you're like one of my older subscriptions, or like one of my older follower people.
That's crazy.
Yeah,
that's funny though. That's awesome. That's awesome.
And then I remember the burping, so I was like, okay, I gotta stop by and say hi. But yeah, but yeah, hey, we'll have to play Toontown sometime. I love playing Toontown, and so we'll have to do some.
You love playing Toontown. This guy's a doctor and everything, like talking like this. It's like, dude, you don't know who you're. It's just crazy because it's like you never know who you're really talking to on the other side of the game. You know, in terms of any video game. So.
That's crazy. Well, I'm glad to see you, my guy. I vividly remember the CEO stuff that you were doing as CEO. So, anyways.
Wow, that's Profiteer. Thank you for the follow. Welcome in.
Profiteer's the best, by the way. You'll enjoy him. He's the coolest.
You said he's the one that I just followed too, right? You said he's your twin from a different dimension.
Yep. He just looks better than me.
Gotcha. He looks better than you. No, you're pretty attractive yourself, brother.
Oh, thanks, man. Thanks, but yeah, he's a good chess streamer. So we'll have to get him to play Toontown. Okay, yeah. We'll have to get him. We'll have to convert him. I like your your background poster, by the way. Is that like a Toon bowling?
So that is a flag. This is my this is my not my Toon, but this is my persona actually bowling.
Okay.
And this is an art piece that I got from a while ago. It was a water paint art piece that I was able to put on a flag. And sure enough, as you mentioned that, I actually just got another flag now that's going to go right behind me on the door. That's right here. That's my bathroom, by the way. So.
Nice.
I got to put that up. I got to find the tape.
All right, well, awesome. I think we better get back to our stream, but hey, let's play some time. We'll do some Toontown.
Sure. Yeah. I'm on. I don't know. My schedule's kind of random, so but my mornings seem to be my personal favorite time to stream in the mornings because it's more quiet. It's more like genuine in terms of my chatters. At nighttime, recently, it just seems like my chatters are unhinged and. Well, I'll say it. They've recently been like, "I want your nipples pierced." And I'm like, "Well, hold on, because I'm not that crazy."
Well, there you go. You're saying the wrong message.
So in terms of, so yeah, guys. In terms of your chat, I'm an entertainer. I'm very funny. I'm a vocalist. I've been doing this for a while, so this is my destiny in terms of streaming and all that good stuff. So yeah, so.
Cool. Well, thanks so much, brother. We'll see you around.
Yeah. Have a good one, all right? Have a good rest of your stream.
Have a good rest of your stream,
Bro,
too,
Pierce
man.
Nipples win. I'm dead, Profiteer.
Yeah, you're going to enjoy Profiteer. He's the best.
All right.
All right, man.
You can cancel this, right? Thank you.
Take care, broski. Ciao.
Bye-bye.
I love it. So we go way back. Literally a year and a half ago, I saw him playing Toontown. Sorry, by the way, if that was distracting. I just had to say hi. Because I tried saying hi last time, it didn't work. And I was like, ooh, gotta say hi. Yeah. Good old... So it was Microzeal before. Yeah. That's funny. It's like a gaming stream where we don't talk. Or like a gaming stream and then a study stream where we don't talk. So the collab is a little bit weird, but we'll have to do some more of Toontown soon. Cool. I love the vibe, man. Keep it going. Keep burping forever. Keep burping as long as you live. May the burps go on. All right. Regarding the study, I see that Daweed is doing some good work. Sidal is doing Amboss block review. Nice. Renata's working hard too on the content review. Dude, weird collabs are the best ones, 100%. And then Crescent's doing streaming. Nice. Amen to that, Crescent. Amen. And then, of course, Profiteer is doing his profiteering thing. I'll check in 6 minutes with a new medical question. We'll see you guys then. Stay frosty, folks. About Moodle Bun? Okay, during the break, we'll have to talk about Moodle Bun, for sure. All right, lock-in time. Here we go. Hey, DTXHS, how many hours should you spend on first aid review? Hey, if you want to come over to our Twitch, we are all kind of gathered there. But I will definitely hit on that in a couple of seconds here. So I see you on the YouTube there. I just sent the Twitch over, but I'll definitely answer that question in 5 minutes or so, whenever our timer runs out. Super good seeing you, though. Super glad you're here. 1 more minute until the break. Okay, we made it, guys. We made it. Okay, so we got a couple of questions that we got to hit. Saydal, are you here? And then I'm going to answer DTXHS's question. Are you here, DTXHS? So let's make this simple. We talked about the bladder and the urethra injuries, right? So, okay, sick. And by the way, I apologize for all the ruckus. I like that guy. He's just a really nice guy. And I have been wanting to say hi for a while. So what we should think about here is there's trauma, all right? And we have to talk about like bladder injuries, right? Your question was about the trauma and bladder injuries. So there are two structures that you should think of for step one that will be damaged here. One is the bladder. DTX down to xylophone. Oh yeah. So there's the bladder and the urethra. And there are different mechanisms here. So pelvic fractures and straddle injuries cause damage to the urethra. And there is a risk of rupture in both of them. And also, the bladder is partially protected by the pelvis, and the urethra is less protected, especially in the male. Also, hey, Renata, hope you're doing well. And so you asked about the bladder injuries, right? And so the most common mechanism of bladder injury is blunt trauma, like an MVC or a fall with a distended bladder. So it's full. And you have pelvic fractures. I'll turn down this so you can kind of hear it a little bit better. And so the anatomy and the dome of the bladder is intraperitoneal. And so if it's ruptured, then urine gets into the peritoneal cavity. And so that's like, I guess, what's high yield about the bladder. And do you have any specific questions? I think one of the most tested concepts about the bladder is the intraperitoneal rupturing, where it's the dome rupturing under the peritoneal versus the extraperitoneal. Because the extraperitoneal, it's more common and it's got the perivesicular space leak and it's localized pain and urinary retention. Oh, also the urethra injury as well. Okay, yeah. We'll definitely talk about that. So urethra injury in males, there's the posterior urethra. So that's like the membranous portion. All right. The posterior urethra, the cause of that is always going to be a pelvic fracture. And there it causes an inability to void and you have a high riding prostate. High riding prostate, and there's blood at the meatus as well. And then there's the anterior urethra, and that's the bulgy, the bulbar spongy stuff. That's the anterior side of the urethra. And that's not pelvic fracture stuff. That's a straddle injury. So think like a bike bar, like a fence. Ouch. Right. And so there it's scrotal and perineal bruising. And so they have blood in the meatus. So if they say there's blood at the urethral meatus, then you should never insert a Foley. Instead, you have to do retrograde urethrogram. That's a little bit more step two. But also the high riding prostate, right? That's the posterior. So posterior is high riding prostate. Posterior, high riding prostate. The perineal and scrotal swelling is the anterior urethral injury. Urinary retention is seen in both of them, though. So just make sure you don't insert a Foley, because that would be so bad if you inserted a Foley. Yep. Management is different, but you don't really need to know the management for step one. Basically, the big things that I would take away is the pelvic fracture is the can't pee, and you have a high riding prostate, and it's the posterior urethral injury. So let me just make this really big here, and I'll do the SparkNotes version of that. The most important thing about the bladder and the urethra is pelvic fractures. For pelvic fractures, which are right, pelvic fractures, you can't pee. You have a high riding prostate, and it's in this posterior urethral injury. A straddle injury is a perineal problem, and it's anterior. Straddle is anterior. And if it's a bladder dome rupture, then it's intraperitoneal, and that causes a urine leak. An intraperitoneal urine leak if you hit the bladder, the dome of the bladder. And so on test day, they'll be saying there's a full bladder, you have blunt trauma, and it ruptures. All right. And I don't know if DTX left or not. I don't know if he's here in the chat, but he asked about how many hours should you spend on first aid review. And I would say usually it's like 150 hours, right? It depends on how you use this, right? Like early prep, 6 to 12 months out, you use it as a reference, and it's like 1 to 2 hours a week. And then dedicated period, 4 to 8 weeks before, it's like 3 to 6 hours a day if that's what you're doing. But most of the times you go through it like 2 to 3 times during dedicated period. You go through UWorld, Anki, Pathoma, and then the final week's cram mode. It could be 4 something hours a day, but I'd recommend doing more practice questions. So yes, annotate UWorld to death. It's super, super efficient, like memory tool, but do at least 2 full first aid passes is what I'd recommend. Also, it's not a textbook, really. It's just kind of like a memory map, right? So you should just definitely get the scaffolding in there. I don't know if you're still on the stream, but that's what I would say. And if you are still in the stream, then stop by Twitch as well so you can more fully participate as well. Okay, Seydal. Great, thanks. Saw a patient once with a urethral injury, referred to our hospital, and guess what? They tried to insert a catheter. No. It's like the one thing, that's like in medical school, the one thing they tell you not to do is don't insert a Foley. That's crazy. That blows my mind. All right. Sounds good. Well, any other questions? Oh, I was going to do one on histamine. A quick question on histamine. So, basically, thermal burns. The earliest change that occurs after you have a thermal burn is going to be the release of histamine from mast cells. Deeper burn wounds from blisters would be like the partial thickness burns is due to the fluid extravasation through the gaps between the damaged venule and endothelial cells. But the superficial stuff is going to be histamine mediated. And then FSH. So FSH secretes inhibin B. From the Sertoli cells in the seminiferous tubules. Seminiferous tubules from the Sertoli cells. And then testosterone and inhibin B induce negative feedback on the LH and the FSH production. So then you get negative feedback. That's another high yield topic. All right, we got 21 more minutes. Time to lock in. Archie says, what pulls you through on a bad day? You know, there's this guy. He's this Asian dude that appears on my feed all the time. He goes, I do it anyway. You know, I do it sad, I do it glad. I feel like that's just what you got to do. Willpower is overrated, my friend. Don't use willpower. Try to just negotiate with yourself once. Your id and your ego. You sit down at a table, you say, what do you want and what do you want? Treat it like they're two adults having a mature conversation, and then decide once. And then it's just a matter of, hey, I'm aligning with my own values, or I'm not. Like, do you want to be in med school or not? Have that conversation once. That way you don't have to renegotiate it every single day and decide it over and over again. Fair enough. What gets you through on a bad day? That's how I would say. In terms of studying, when you don't want to do it, you remind yourself why you did it. Then do accents. Accents get you through on a bad day. That's right. When you feel low, like Danya. Yeah. When you feel low, Archie, don't you have a family too? Because I imagine they'd be really big motivators for you. But whenever you feel low, cognitive behavioral therapy is really helpful for me. I try to think, for instance, you might say, oh, well, not a lot of people are watching the videos or something like that, or not a lot of people are like signing up or whatever it may be. Well, you just have to remind yourself about like the reasons for which people do things. They have a million different things that could pull them away from the stream. And plus that doesn't even necessarily mean anything about me as a content creator. And you can kind of go down these like checkpoints with cognitive behavioral therapy and check yourself at every junction. Sadal says, what do you think Harvard students do that other med students lack? Well, one of my friends, I asked her because she kills it. She's like the best at Harvard Med School. And one thing that she said is I do the questions that I get right twice and the questions that I miss 4 times. So she works crazy hard. And I remember like at Harvard, I'd try to get my friends to be like, hey, let's play Frisbee, And they'd be like, I can't. I have a test in 3 weeks. I'd be like, what are you talking about? You have a test in 3 weeks? That means you can play Frisbee. But they just work so hard. Truthfully, they work so hard. And there's also this blend of just natural intellect, I would say, coupled with indefatigable work ethic. So, I mean, Harvard students in graduate school and medical school are different than those in undergrad. Those in undergrad are like pluripotent cells, capable of doing so many things, Renaissance men, women. You become more specialized in grad school, I'd say. All right, Archie, I'm rooting for you, man. I'm rooting for you. But if ultimately, though, I wouldn't say that there's like a big, huge difference. It's like Obama said. He's like, Barack Obama once said, he's like, you realize we're all just folk. We're just people, right? There's no huge categorical difference between them. And it's more discrete than you think. And one thing that a lot of people suffer from at Harvard is imposter syndrome, which you wouldn't think that's true, but yes. The literature backs it up that people suffer the most from imposter syndrome in those academic environments, right? And also they have upside down duck syndrome. They say, oh, life is so hard, everything's so bad, and they're like killing it. So I have a lot more to say about that, but that's probably enough for now. All right, 17 minutes. Time to lock in, shall we? 17 minutes. If you guys have anything you want me to cover in that time, just let me know. We'll see you guys soon. Time to lock in, and we'll take a stroll through Hogwarts. Let's do it. Yeah, it's pretty bad for sure. Maybe I'm just projecting now. Yeah, that's fair. Yeah, I agree. I definitely agree with you there. Definitely agree with you there. Profiteer, it would make my day if you played Tuned Down. That'd be amazing. right. We just finished our little lock-in section there. So, how are you guys doing? I just had one little note here that I wanted to make on some high yield content, and that would be deadlines for disorders. So let's do that now. Okay. Nice, Prophet. So here we go. In psychiatry, we have to know the timelines for specific disorders per the DSM-5. So here they are. Brief psychotic disorder is greater than 1 day but less than 1 month. Schizophreniform is greater than 1 month but less than 6 months. Schizophrenia is greater than 6 months. Schizoaffective is greater than 2 weeks of delusion or hallucinations, but in the absence of prominent mood symptoms. And then delusional is greater than 1 or equal to 1 delusion in at least 1 month with no other psychotic symptoms. Normal functioning apart from that. So there you go. It's all about timelines. And of course, some minor distinctions between these psychotic disorders. If you found this helpful, then like and subscribe. They diagnosed you with schizoaffectiveness? Nice. That's the better way to live life, honestly. Schizoaffective disorder is if you have a mood episode with concurrent active phase symptoms of schizophrenia and also greater than 2 weeks of delusions or hallucinations, but you don't have any prominent mood shifts. So that means you can experience life probably more vividly than a lot of people do. And, you know, there also would be some active phase, you know, schizophrenic tendencies, but yeah. Amboss, did you do a block and review? How did it go? Sidal, how'd it go? Nicely done. Congrats, by the way. Yeah, I wonder why they gave you schizoaffective. Because you have to have concurrent active phase mood symptoms of schizophrenia in order to get the diagnosis, per the DSM-5. So, 2 weeks of delusions, hallucinations in the absence of prominent mood symptoms. But it's, you know, objectively though, you can experience things that other people don't, which is powerful. I don't know. And congrats, by the way, Sidal. Oh my gosh. Holy cow. That's insanely good, Sidal. Wow. When are you taking the exam? Congrats, by the way. That's phenomenal. Nice, Crescent. That's awesome. Me neither. What the heck? Nice. 85% is amazing. When are you taking the exam? Next week. That makes sense. Okay. You taking step 1 then? Light flashes, little light orbs and sprites. Nice. Cool. C. diff, enterotoxins, and also the B. Nice. That's amazing. You got this. Easy. Well, sick. Good stuff, y'all. Good stuff. You guys enjoying the stream? Is there anything else that you'd like to see and have kind of change here? Any other thoughts? Thanks to the MBME reviews. I'm so glad they've been helpful. Sidal, do you have any feedback for me? Anything that you'd like to see? I know MBME 30 is highly requested. I'll get to that one soon. And also on the stream, I was thinking I really like the Hogwarts walkthrough. Like, it's just so fun to just get that map in my head, you know? But this is kind of fun, like a little notes iPad on the side, and you kind of pull it out. I don't know, I'm kind of digging this whole vibe. Yeah. Well, a little short break. We got 5 minutes. I think what I'll do is I'll just keep making notes. I'm going to release a guide here soon. I've started to stream daily, yeah. Almost every day. It's just really fun, you know, because I have work to do and might as well passively just stream. So I try to stream as much as I can, but I think I'll start to stream every day. Bro, the Hogwarts walkthrough is fire, yeah? Yeah, I think so too, right? Isn't this cool? It's like, ooh, welcome to Hogwarts. I love it. And then listen to the music in the background. Ooh, it's like raining too. I've got rain sounds going on for 11 hours. I literally just got goosebumps, guys. Literally just got goosebumps. But yeah, hopefully this is a good way to just kind of lock in, you know, for a bit. Lock in, do a tomato, lock out. Kind of just follow on that path. Yeah, that's nice. It's a good time. Renata, congrats. Yeah, I got the goosebumps crescent. I got him. Macrozeal. Renata, how's it going? Looks like you got a lot of tasks done today. This is awesome. Music helps me focus too. You're taking a break? Be back by 9 p.m. Eastern time? Whoa, that's so long. That's a long, long break. You're going to be gone for a long time, Renata. Hopefully we'll be here when you get back. But super proud of you for locking in. Super proud of you. Renata's awesome. Okay. That's good stuff. 9 p.m. Eastern time. Cool. All right, folks. 3 more minutes. And then what other tasks are we working on? Nice. By the way, Renata, you can do !" done, and it'll mark it as done. What else? Nice. Well, the YouTube is harder than I thought because the API key is not cooperating with the OAuth system. So I'm going to have to work around that tomorrow. I already exhausted all my API calls for the day. All right. I'm going to make a question on primary biliary cholangitis. What would be a good question? I guess just like an autoimmune liver problem. Maybe we could ask about the alkaline phosphatase levels. The lymphocytic infiltration, granulomatous destruction of the bile ducts. Graft versus host disease, immune-mediated destruction, lymphocytic infiltration destruction, PBC. Yeah, for sure. Hey, was that a mix block that you did that you got an 85 on? Because that's just incredible. Really good job. You're so set. Like if that's a mix block of just random questions that you haven't seen before, like that's truly amazing. Yeah, that's a good suggestion. We can definitely do that. Oh. Okay. So compare it with primary, okay, yeah, sclerosing cholangitis as well, for sure. Nice. Yeah, there are some fairly funny mnemonics that I heard before that kind of help solidify this. But primary biliary cholangitis, primary sclerosing cholangitis. So they're both autoimmune. So cholangitis is going to be destruction. And sclerosing cholangitis is autoimmune fibrosis and strictures. Fibrosis. All right. And yeah, good job saying hi to everybody. It's Avanda. Oh, man. So the demographics, middle-aged women. And then sclerosing is young to middle-aged men. And here, this is really helpful, Sidal. Women. Somebody told me this. It's because you think of the sons of bitches. Women be. And then men are the sons of B. Okay, so you get what I'm saying, right? So the demographic, you can memorize it easily just by looking and paying attention to B and then S. Yeah, so that always stayed with me for a while. But you have tons of other associations with like other autoimmune conditions with primary biliary, like Sjögren's, rheumatoid arthritis, Hashimoto's. And then this one is just going to be ulcerative colitis is its association. And then Pianka, you have to memorize. And I would just say memorize one of these, like Pianka. And then the other one is the other one, right? Antimitochondria. So AMA, ask me anything. And the enzymes, they both have elevated ALP. And the biopsy, there's a lymphocytic infiltrate in the granulomas with primary biliary lymphocytic. Lymphocytic infiltration, and then there's onion skin around the bile ducts. Onion skin for primary sclerosing. And so how they present too is like fatigue and pruritus for both of them, but then here you have right upper quadrant pain in sclerosing, whereas for primary biliary, it's going to be predominantly jaundice. So it's really pretty like a sexually dimorphic disease as far as they go. And the cancer risk as well. Cholangiosarcoma for this one, cholangiosarcoma with the S, and then hepatocellular carcinoma would be for the biliary. Hepatocellular carcinoma. Whereas this one is cholangiosarcoma. And then the treatment here, there's no treatment. Eventually you have to do a liver transplant for PSC, but then you do Ursodiol is your treatment for PBC. Crescent says he's got to go. Therapy, leave and lurk up. We'll be hanging up with my friends also. Okay, sounds good. Good to see you. Blake, I don't know if you have any of the means of communication off here. Yeah, visit me at blake@ivtutoring.net is my email. So feel free to message me. It goes for anybody here. Definitely. Send me a message. That'd be fun. All right. So here's what we got. And I'll make a quick video on this as well. And here we go. So 3, 2, 1. Gotta find the record button. Okay, there it is. Okay, so PBC, one more time. It is blake@ivtutoring.net. I'll write it down in the chat. 1 second, and then I'll do a quick video. The chats. blake@ivtutoring.net. That's the one. Of course, yeah, this is so fun. I love this stuff. Okay, so quick video on this. What's the difference between primary biliary cholangitis and primary sclerosing cholangitis? Let me pull up my magic iPad and we'll dive in. So primary biliary cholangitis has autoimmune destruction, and then primary sclerosing is seen with fibrosis. The sites that are affected are different. Here we have intrahepatic for primary biliary, and women is the demographic that will get this, middle-aged women. Whereas here it's intra and extrahepatic bile ducts, and this is young to middle-aged men. The associations are very different as well. So the associations for primary biliary is going to be other autoimmune conditions like Sjögren's and rheumatoid arthritis, whereas for primary sclerosing, it is just ulcerative colitis. Also, a huge difference that they love testing is the antibodies, right? AMA, memorize that one, ask me anything versus the Pianka. All right, and the way that you remember this is these ones are the sons of B and these are the B, right? Because of the demographic that they affect. The sons of B's and B's, right? And the imaging isn't going to be as high yield, but you can know that there's beating of the bile duct in primary sclerosing cholangitis. On biopsy, you'll see a lymphocytic infiltrate with biliary, whereas onion will be seen with the sclerosing one. The cancer risk is different here as well. Hepatocellular carcinoma is seen with primary biliary, whereas with sclerosing is cholangiocarcinoma. You know that because the C, sarcoma, SC sarcoma. There's actually no cure, and eventually you have to do a liver transplant for the sarcoma, angiosarcoma, whereas you can do ursidiol for the primary biliary cholangitis. All right, if you found that helpful, then like and subscribe. And by the way, I know you know this, but I feel like I should explain for anyone who may think I'm messing around with their task list. I'm trying to become a full-time streamer, so keep myself present in the communities adjacent to my channel is something I didn't make enough of a priority unless I remind myself. Yeah, that's fair. That's fair. Dude, I wish you so much success in that joy, in that endeavor. Like, I really, really want you to succeed. Yeah. No, I love it. I love using the task list. That's amazing. I'm super happy for it. Like, that, I'm elated by that. That's awesome. Yeah, and it's just fun. Tea time. Nice, yay, Sidal's doing tea time. Dude, I'm super excited for your profiteer. I really want it to take off. Yeah, I hope you can do this full time. That'd be awesome. Tea time. Hey Sidal, here's a question for you. Somebody presents with tea and toast. Tea and toast diet. What's high yield about tea and toast diet? The tea and toast diet? A lot of things, right? Iron, nice. Yeah, nutritional deficiencies, definitely iron. What else? Vitamin C, nice. Yeah, 100%. A big one too is protein, right? Muscle wasting. B12, macrocytic anemia, neurosymptoms. Yeah, vitamin C. Calcium, vitamin D, so osteopenia. You can see osteoporosis and fractures. Zinc, impaired wound healing. You can have just so much from only having tea. But typically this is going to be like elderly patients living alone, fatigue and falls and stuff, and they have anemia, low albumin, vitamin deficiencies, and they're like frail and thin, and they have bruising and poor dentition as well. Just a fun little question. You brought it up. Yeah, eat an apple every once in a while. Jeez. Right, Archie? Right? Profiteer says, strictly speaking, also I'd like to think I'm helping work out bugs in the co-working software Blake is building, because that's an excuse. Yes, 100%. No, it really helps. I love it. I'm proud of this so far. It's been fun. Although it is impossible to get YouTube working. You got a question like that in MBME? Nice, nice. Sidal, have you taken all the MBMEs? I was thinking about doing a series where I'd go 1 through 30. Like, wouldn't that be crazy if I just did 1 through 30 for a while? I don't know. A quick question would be a nice little addition. A quick question would be a nice little addition. Wait, to what? I'm confused now. A quick question to what? Oh, a quick question is a nice little addition to your actual tea time. You've done 25 to 31. Okay, good. Nice. How long did you prepare? Because you're killing it with your 85%. That's really good. All right, folks. I think we'll do like one more timer. Let's see how the timers are going before I start to just wipe out. Before I need to go to sleep. It's just so fun, though. All right, maybe this will be our last timer. We have 15 minutes of work, okay? And then we'll join together and have a little tea and toast. So we'll see you then. Okay. 15 minutes starting now. Oh wow, 7 months. That's quite a long time. 8 hours a day, solid. Yeah, I like that. Keep it there. No more, no less. That's awesome. You're totally gonna pass. No doubt about it in my mind. Alrighty. 16 minutes, folks. We'll see you in 16. Oh, quick question session is what I think you should add to the viewers. What would that look like? Do you think it'd be like, I do like a rapid review of like 60 questions, like. Yeah, that'd be good, huh? I'm making recordings of all of these, and then I'll chop them up later and post them. But that sounds like a good idea. I'll do some rapid reviews as well. I'm making a course as well that is going to be 7 days of just high yield information. So that should be fun as well. Okay, time to lock in. Or active learning. Gonna forget the one you asked me, the tea and toast. Yeah, definitely. Quick questions, back and forth. Yeah, that's fair. That's fair. Active learning. That's a good idea. Okay, lock in time. Here we go. Well, first time talking to Vonda since the news. Which one is Vonda? I don't know if I know Vonda. Vonda Savkina. Well, that's a high quality camera. What's her ELO? Wow. Really nice camera, that's for sure. Yeah, that's tough, man. As soon as the stream ends, I'm gonna be watching a bunch of videos. I'm gonna watch his last stream. Okay. Anybody finish any tasks? I think I'm probably gonna end the stream here after this last little session. Uterine lyomas, fibroids. Cause irregular uterine enlargement. Irregular. Yeah, I know. I found it on YouTube though. I'm gonna watch it after this. Ugh. Oh, so horrible. Ugh. Causes pelvic pressure. Posterior lyomas can cause constipation due to the pressure of the colon. Adenomyosis. Diffusely tender uniform. It's adenomyosis. Make a table. All right, we'll do this topic here. But yeah, he was tweaking out. There was something wrong with him. I saw. I think he had insomnia and maybe some medication. It's really sad. Looking back, it's clear he struggled with insomnia for a long time. Thought it was normally just love to play bullet chess. Yeah, like I remember when he played all night against Alireza Firouzja. Yeah, that's crazy. Yeah, like, it's crazy looking back, you know? Wow. All right, I'm going to do a video on this one here. Here we go. 70% of women develop uterine fibroids by age 50. So a subserosal fibroid grows in the posterior uterus. Then it can press against the colon and it'll cause chronic constipation and also pelvic pressure. So we have to know all of these answer choices. Adenomyosis, this is diffusely enlarged and a tender uterus with heavy and painful periods. Diffusely enlarged. Cervical cancer, that present with postcoital bleeding and also visible cervical lesions, and there's no bleeding. And the question stem, so that's not the right answer. This is leiomyoma, causing pelvic pressure. Posterior vaginal wall prolapse that would have a bulge that you could actually palpate in the vagina, and also constipation would be present. And then rectovaginal endometriosis that cause dyspareunia. Which is painful sexual intercourse and also cyclical pain. And she has no pain or cyclical symptoms. And so we have to understand the uterine anatomy in relation to the GI structures. And we know that the fibroid location affects the symptoms. And we have to recognize that subserosal means that we had some pressure effects, not bleeding. Because retrovaginal endometriosis would present with a lot of bleeding. So irregularly enlarged would suggest a fibroid, not adenomyosis. And the pelvic pressure tells us that it's posterior mass. And that no pain and normal periods rules out endometriosis and adenomyosis. So that's the lay of the land for your question like this. Yeah, it's crazy, man. It really makes you think about life too, you know? We're not here for a long time. And he had everything, honestly, from the outside looking in. But it's just tough. It's really tough. Devastating, really. Devastating. I still haven't had time to like process it, honestly. Well, are you gonna stick around for the rest of the day? I guess we'll see you. We'll see you around. I think I'm gonna catch some sleep myself, lest I have the insomnia. I might do some editing or something like that. But this has been a fun stream. I've really enjoyed it today, and it's fun seeing you. And it was fun playing the chess game yesterday. That was awesome. And I got to meet Chess Noob and some other cool people, so love it. This has been fun. All right, Profiteer. I'm gonna check out now. Sidal, Archie, Crescent, everybody, see you guys later. All right, man, take care. Have a good sleep. If you ever sleep someday. Nice, I love this. This has been great. All right, take care.